So this is to cover those pages that you were assigned to read on your antipsychotic medications, starting with the basics. I'll just go over the basics real quick. So your brain is made up by a whole bunch of nerve cells, which we're going to call neurons. These neurons send communications with neurotransmissions, which occur by neurotransmitters that are chemicals. And they kind of pass along. Some of them are excitatory, that speeds things up. Some of them are inhibitory, that slows things down. And essentially, we've developed medications that can either slow them up or speed them up or slow them down, depending on what symptoms our client's having. I have a little bit of basic psychopharmacology information. So, psychotropic drugs are used to treat the mental illnesses. They're divided into antipsychotics, antidepressants, mood stabilizers, stimulants. We're just going to be talking about antipsychotics for this one. Some key terms is listed here. We have efficiency, which is the maximal therapeutic effect, potency, which is the amount of drug needed for that maximum effect, half life, which is the amount of time that it takes for the drug to remove half of the blood from the bloodstream. And then the role of the FDA, which is responsible for supervising and testing marketing medications for public safety. So they're going to be drug trials, monitoring the effectiveness and side effects of drugs. There's two terms associated with this. We have off-label and black box warning, which we'll discuss on the next slide. This is just good to know. It's not need to know information. Off-label drug use. uh, So this is when they were doing trials and they realized that the medication kind of helps something else. Um, One of the videos that we had you watch talked about Thorazine. I think that was the rise and fall of the asylum. And they talked about how Thorazine was originally created for nausea, and they realized that it had a really good calming effect. So then Thorazine was then labeled as the chemical lobotomy. Other medications that we use tons of medications off label. Beta blockers are another one, right? We give beta blockers to people for anxiety. Black box warning are serious life threatening side effects. And some of these drugs, specifically the antipsychotics, have some black box side effects that are obviously serious and life threatening. Principles, right? We want to give a medication so that it targets the client's symptoms and provides them relief. We want to make sure that we're using the lowest effective adults, the lowest effective a dose, because we know that the lower the dose, the decreased risk of having some of those black box warnings. These clients are going to need follow-up care. The rationale behind lower doses for older adults is because of as older adults, your ability to metabolize the medication reduces. Kidneys, livers, all of that stuff have declined. And you should have learned about that last semester, or if you're a traditional student, a few semesters ago in pharmacology. Um, Many of these meds we can't just abruptly stop. We need to taper them. If we completely stop them, we can have issues with recurrence of symptoms or withdrawal. A few of the medications we'll talk about, if we have some of these black box effects, we might have to just stop them. What their follow-up care is going to be, a lot of psychiatric medications are controlled substances. Clients need routine follow-up to make sure that they're not having the development of a black box warning, as well as reassessment for continued care. We want to use the simplest regimen possible. So, Remembering to take one drug is a lot easier than remembering to take multiple drugs. We know that simple regimens usually result in better compliance. So, our antipsychotic drugs typically are broken down into two. However, now we're having third generations, which are really cool. Your first gens, which are also listed as conventional, which are sometimes spoken about as typical. These guys block dopamine, and they block dopamine in all areas of the brain. So we know that positive symptoms are a result of too much dopamine. Negative symptoms are a result of not enough dopamine. Cognitive symptoms and mood symptoms also are related to not enough dopamine. There's also um, prolactin levels that can be affected by reduced dopamine levels. The reduction of dopamine will cause an increase in prolactin, which can lead to a reduced sex drive, breast development, and even lactation. So, our first generation drugs are great because they're really good at turning off those positive symptoms, which we know are kind of the riskier symptoms to have, right? Those positive symptoms are your hallucinations, your delusions, your bizarre behaviors. However, it worsens your flat affect, your mood issues, your cognitive issues, and it increases your prolactin level, which is going to give gynecomastia, lactation, and reduced sex drive. So a lot of patients will stop taking their antipsychotics because of all the other worsenings, right? If you're having delusions and hallucinations, sometimes you can deal with that so that way you don't have, you know, the other symptoms. We then came up with atypicals, also known as second generations. Atypicals block D2 just like the first gens. However, they also act on serotonin. And by doing this, the negative symptoms and the cognitive symptoms are actually improved because if we have that little increase in serotonin. Your third generations are called dopamine system stabilizers. And what these actually do is they're supposed to stabilize the dopamine and preserve it and enhance it. So when it's too low, it's going to bring it up. And when it's too high, it's supposed to drop it down. Um, so why do we use antipsychotics? We use them to treat psychosis. And again, the main mechanism of action is that it's going to block the dopamine. Side effects. So we have side effects that can be broken down into neurological side effects and then non-neurological side effects or other side effects. One cluster are these extrapyramidal symptoms, EPS. And EPS can be, a client can have one or they can have all three of these. Um, there's acute dystonia, there's pseudoparkinsonism, and then there's akathisia. So acute dystonia, and I have a link that I'm going to put to this that kind of shows patients going through some of these. So the symptoms, they can have torticollis, which is going to be, well, first let's start off with it's a very painful rigidity of the muscles. So if it's torticollis, it's affecting their neck. And when it affects their neck, it can go into laryngospasms, which can cause respiratory complications. It can affect their tongue, which can cause difficulty swallowing. They can also have these spasms and painful rigidity of the muscles in their whole entire body, or they can have an ocular crisis where their eyes roll in the back of their head and lock. This is a medical emergency if it's involving their airway. We would treat this with cogentin. Um, which is an anticholinergic drug. Or you can give them Benadryl. And you can see this in table 2.4 in your book. Um, Continued treatment of this is sometimes they can reduce the dose of the medication, and sometimes they have to remove the medication altogether. By adding the anticholinergic, it can stop the reoccurrence of this from happening. If you add cogentin and it reoccurs again, the drug would then have to be discontinued completely. The next one is the pseudo Parkinson's. Again, you would want to add an anticholinergic on, or you would want to change their medications. Pseudo Parkinson's symptoms resemble those of Parkinson's disease. So the client's going to have some stiffness, they're going to have stoop posture, mask like faces, decreased arm swing, they're going to have shuffling, they might have that cogwheel rigidity, which is ratchet like movements of their joints. They could have drooling, tremors, that pill rolling movements, which is that finger and thumb. Again, you would treat this by lowering the dose of medication, adding on an anticholinergic, which cogentin, which is benzotripene, and remember adding on that anticholinergic. We'll talk about this more in a few slides, but that's going to cause that dry mouth, constipation, and all that stuff. The other thing that they can have is akathisia. Akathisia, your patient is going to report having this intense need to move about. They're going to appear restless. They might appear anxious. They might appear agitated. They might have some rigid posture or gait. They're going to have some spontaneous gestures going on. The feeling of that internal restlessness and inability to sit still often leads clients to just discontinue their antipsychotic medication altogether. Akathisia can be treated by changing the antipsychotic medication. Sometimes we can add on beta blockers, anticholinergics, or benzos to help with it. Some other neurologic symptoms you might have would be neuromalignant syndrome, NMS. You could have tardive dyskinesia, and then the anticholinergic side effects. So, talking about neuromalignant syndrome, this is a potentially fatal reaction to the antipsychotic drug. The major symptoms of NMS are rigidity, high fever, and autonomic instability. So they're going to have unstable blood pressure, diaphoresis, pallor. They're going to have delirium, elevated levels of their enzymes, particularly in their CKs. NMS most often occurs in the first 2 weeks of therapy or after an increase in dose. It can occur at any time in their treatment. We have to treat the client for immediate discontinuation of the antipsychotics. We need to do supportive measurements. So, usually they're going to be dehydrated and they're going to be hyperthermic. So, giving a patient a Tylenol is not going to treat this fever. These fevers are going to be like 103, 104, 105. We usually have to give them Tylenol as well as put them on cooling blankets. Sometimes we'll use cooler saline to infuse. That'll help with their dehydration as well as help cool them from the inside out. After an episode of NMS, the decision to treat the client with antipsychotic requires a full discussion between the client, the physician, to weigh the relative risks of this potentially happening again. Tardive dyskinesia, this is involuntary movements. Once it happens, it is permanent. One of the primary goals when we're treating with antipsychotics is to keep the therapy dose as low as possible to reduce the risk of this happening. atypicals are less likely to cause it. We can monitor our clients with an abnormal movement scales. About 20 to 30% of clients with long-term treatments develop it. Again, the lower the dose, the less likely it's going to happen. Some examples of it, they might have tongue thrusting and protruding, lip smacking, blinking, grimacing, um, excessive unnecessary facial movements. We do have some medications now that are aimed at treating this and reducing the symptoms. And those are listed here. I'm not going to try and pronounce them, I'll butcher them. Anticholinergic side effects. So, anticholinergic side effects, your cues for that, which is symptoms. Um, Patient could have orthostatic hypertension. So, when they stand up, their blood pressure drops, they get dizzy. They're going to have dry mouth, constipation, urinary hesitancy or retention, blurred vision. Um, this can usually happen and then it's going to start to decrease within 3 to 4 weeks of being on the medication. It will never completely stop. Clients that are taking anticholinergics to help with their EPS symptoms are going to have increased risk for anticholinergic side effects. And that's why it's really important that we give them those calorie-free beverages, that we do the sugar-free candies. Those are going to help alleviate the dry mouth. We're going to need to use stool softeners to help with constipation. Want to make sure that they're getting plenty of water, but you want, water or those non-sugar drinks, um, grains, fruits, and other things to prevent constipation. Other lovely side effects. So we have those increased prolactin levels, which are going to cause the gynecomastia, lactation. Gynecomastia would be growing breasts, men particularly. Women, we're supposed to have breasts. So weight gain, um, metabolic syndrome, cardiovascular effects such as the lengthening of the QT, which can lead into a lethal cardiac arrhythmia. And then we have agranulocytosis, which is having an extremely low neutrophil count. We know that neutrophils are a type of white blood cells that help us fight off germs when we're sick. So it can actually put you at risk for getting an infection that would not normally kill you, but since you're having the agranulocytosis, you're at an increased risk for death. Teaching, we want to teach them to adhere to their regimen, right? We know that if the client adheres to the regimen, it is less likely that they're going to have a relapse. Um, we want to teach them about side effects. We want to teach them that if they're having their side effects, to let us know about their side effects so we can let the prescriber know and that they can alter their regimen, right? They might need to add on that anticholinergic, might need to change their antipsychotic medication. If a client misses a dose, and it's like 3 to 4 hours late, they can take the missed dose. Typically, if it's more than 12 hour or more than 4 hours overdue, they just take the dose when the next one is due. If your client has difficulty remembering to take their medications, sometimes we can do, dose trackers, pill box. I know one pharmacy right now actually sends out pre-packaged with the day and the time on the pack. So it's all individually dosed, which really helps. So here's a question. Which drug is classified as a conventional antipsychotic? And the correct answer is C. Um, Clozapam and risperidone are considered second generation, and um, D is a third generation antipsychotic. And your book has all of the um, first gen, second gen, conventional would be your first gens, your typicals. That is the end of this slide or show. lecture.